Welcome back to MedMythbusters HIV. I'm Rachel Deer with DKB Med. In this fourth and final episode of this year's series, we talk about general medical care and comorbidities in primary care for people living with HIV. I'll turn things over to our faculty in a moment, Asia Sullivan. She's a certified physician assistant based in Los Angeles, California. Our learning objective is describe preventive health and screening protocols for people living with HIV. Asia, take it away one last time.
Thank you, Rachel. First myth, people living with HIV have the same comorbidities as people without HIV. This one is, in fact, a myth. HIV is associated with chronic immune system activation and inflammation, which can accelerate the aging process. And so cardiovascular disease, bone density loss, kidney disease, and certain cancers can occur earlier and at higher rates in people living with HIV. So this is something we have to be aware of and screen for. Next one, HIV infection itself does not independently raise the risk of cardiovascular disease. This is a myth. So because HIV causes persistent immune activation and systemic inflammation, this alone independently drives atherosclerosis and overall cardiovascular risk, even beyond traditional risk factors such as smoking, hypertension, and high cholesterol. People living with HIV have higher risk of myocardial infarction compared to HIV-negative peers, even with viral suppression, and sometimes certain ART agents can contribute to dyslipidemia. Risk of cardiovascular disease is twice as high in people living with HIV, again, because of the immune activation and residual inflammation. And what the REPRIEVE trial showed us, it randomized people living with HIV who had low to moderate cardiovascular risk to either a placebo or a statin. And what they saw is that the statin group had a 35% reduction in major adverse cardiovascular events, and that led to the recommendation of moderate intensity statins for most people living with HIV between the ages of 40 and 75 with low to moderate risk. So again, we might have been, or we definitely were, underestimating the need for statin therapy in people living with HIV prior to the REPRIEVE trial being reported. And we will, again, certainly link to those guidelines and resources on our website. Metabolic dysfunction-associated steatotic liver disease is no more common in people living with HIV. This is a myth. MASLD is significantly more prevalent in people with HIV due to multiple different factors: chronic inflammation, history of ARTs, insulin, alcohol, etc. And so liver disease has actually become one of the leading causes of non-AIDS mortality for those living with HIV. So it's important that we consider this and think about screening people for liver fibrosis, especially if they have additional metabolic risk factors, even if they have a lean body type. So just to give you an idea, so people living with HIV have a higher prevalence of MASLD, about 44% versus 35% in the general population, and a higher prevalence of lean MASLD. So again, we cannot just look at a person or use only their BMI or their body type to determine whether or not they may be having issues with liver steatosis. Again, MASLD is an independent cardiovascular risk factor, and so it's important that we do not miss this in our patients living with HIV. In addition to those standard risk factors that we may think of, including diet and physical inactivity and obesity, there are also some direct effects of HIV on the development of MASLD. So we think again about that immune dysregulation, lipodystrophy, history of ART, and opportunistic infection. So it's very multifactorial in what leads to MASLD in our patients living with HIV. Next one. People living with HIV are not at higher risk of developing osteoporosis. This is, in fact, a myth. Patients with HIV have a higher risk of low bone mineral density and fragility fractures than the general population. Because of this, baseline bone density testing or DEXA scan to screen for osteoporosis is recommended in postmenopausal cis women and cis men who are over the age of 50. Screening for trans individuals should follow national recommendation based on individual risk. So again, screening with DEXA, so bone density testing, all men with HIV who are 50 and older, and all postmenopausal women with HIV, and again, at any age, depending on their independent histories, if they've had major fragility risk factors or are at high risk of falls. We will provide you these guidelines again on the website as it relates to bone density testing in patients living with HIV. Next one. Cardiometabolic risk management in people living with HIV follows the same approach as in the general population. This is a myth. So, while the same risk factors apply, HIV specific considerations can complicate management. So, what ART the patient is on or has been on can influence metabolic outcomes. Integrase inhibitors can sometimes cause weight gain. Older medications have been associated with dyslipidemia. And we also have to consider drug drug interactions when we're choosing medications to mitigate cardiovascular risk. Next one. Mental health considerations are the same for people living with HIV and the general population. This is a myth. People living with HIV face higher rates of depression, anxiety, substance abuse, and stress than the general population. And this can really directly impact engagement in care, and it can be an adherence to staying consistent with antiretroviral therapy. So, in primary care, we really should be more proactive about our patients living with HIV, screening them for depression and other mental health issues, and having a plan to address those. We can think of mental health as a core part of HIV care, not something to be managed separately. So, when patients are feeling confident about their mental health, their depression and anxieties are well managed, they are better able to stay engaged in care, take the medication as prescribed, and therefore do better, have better outcomes. Next one. People living with HIV are at higher risk for certain cancers than people who are not living with HIV. This one is a truth. People living with HIV are at higher risk of certain cancers, including anal cancer, which is the fourth most common cancer among people living with HIV. There are guidelines for screening for anal cancer, and the recommendation is for annual anal cancer screening for men who have sex with men who are 35 years or older and transgender women who are 45 years and older. And we will link to these guidelines on the website. People living with HIV are also at higher risk of cervical cancer. So, women with HIV have a higher incidence and persistence of HPV relative to women without HIV. And the recommendation is for those with a cervix who are living with HIV to be screened for cervical cancer annually. Next one. People living with HIV should have the same vaccinations at the same time as people without HIV. This one is a myth. People living with HIV have unique vaccination needs and may need certain vaccines earlier in life than those who are not living with HIV. Those vaccines that have specific recommendations related to HIV status include COVID, hepatitis, meningitis, pneumonia, HPV, shingles, and RSV. And we will link to these recommendations for vaccines on the website as well. One of the more recent vaccine guidelines is for RSV, respiratory syncytial virus. It is recommended to have a single RSV vaccine for people who are living with HIV aged 50 to 74 and who have a CD4 count of less than 200 or who have comorbid chronic conditions that may increase their risk for severe RSV. Meningococcal vaccines are recommended for all people living with HIV who have not been vaccinated previously. And for those who have been vaccinated previously, repeating vaccination every 5 years throughout their life. And that is specific to the MenACWY vaccine. MenB, the serogroup B, is not routinely recommended unless there are some special circumstances. Regarding zoster vaccination, all people living with HIV who are 18 and older, regardless of CD4 count or previous history of herpes zoster, should get 2 doses of the zoster vaccine 2 to 6 months apart. Thank you for watching this episode of MedMythbusters. I hope you learned a lot and that we busted some myths surrounding HIV trends, treatment, and prevention. Thanks again for watching.
I think we learned a lot today and throughout the series. Thanks to Asia for debunking those myths and pointing out the truths about HIV. If you missed any of our previous 3 episodes, be sure to check them out. If you'd like to claim credit, please click the Claim Credit button to take the evaluation. Your thoughts and comments are important and help us develop additional education for MedMythbusters. For CME information, go to mythhiv.dkbmed.com. Did you know DKB Med provides no-cost continuing medical education for clinicians? Well, we do, and you could create a free account if you don't have an account already at dkbmed.com, and you could start earning your free CME and CE credits. And thank you for watching. We'll see you next time.